Hello, and welcome to today's webinar, The Healthcare for the Homeless Model of Care. I'm Caroline Gumpenberger, and I'll be the moderator for the webinar presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 15 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you're having technical issues, you may also call the Council's office at 615-226-2292 for assistance. And now I'll turn it over to our first presenter, Alaina Boyer.
Hi, and thank you. Thanks for having us. My name is Alaina Boyer. I have been here at the National Healthcare for the Homeless Council since the fall of 2016. I am Director of Research, where we conduct research with our Healthcare for the Homeless communities and other research projects, often related and partnered with academic institutes. We also help support with research-related technical assistance questions, as well as developing some publications related to fact sheets and white papers. Some other members of my team are also focused on trauma-informed organizational care, as well as enabling services. So that gives a little snapshot of what the research team does here at the Council. And Eowyn, would you like to introduce yourself briefly?
Yes, hello everybody. This is Eowyn Rieke. I'm the Associate Medical Director of Primary Care at Old Town Clinic at Central City Concern in Portland, Oregon. And I have worked in homeless health pretty much most of my medical career. I started a homeless health clinic in a soup kitchen when I was in residency. And I've also done work on mobile medical vans, in shelter-based clinics, and in brick-and-mortar clinics. I am also serving this year as the chair of the Clinician Steering Committee for the Clinicians Network of the National Healthcare for the Homeless Council, which is part of the reason why I was invited to come and talk with you today. Alaina?
Great. Well, thanks. To get us started, I thought we would just recap a little bit on our learning objectives. So hopefully by the end of our presentation today, you would have walked away being able to describe the connection between homelessness and healthcare, be able to identify specific health needs of patients experiencing homelessness, as well as explain key characteristics of the healthcare for the homeless model of care and how it is implemented. So I'm really excited to co-present with Eowyn, who will help bring a lot of pragmatic and realistic examples and experiences to the presentation today. To give a brief overview of what we have in store is we'll begin with defining homelessness and health, and then we'll talk about the healthcare for the homeless model of care and just really how unique that is and how different that might look than other traditional models of care that you might come across from day to day, and really kind of how that model of care breeds innovation and quality to our patients. So on that note, I am going to hand it over to back to Eowyn so she can talk to us about defining homelessness.
So there are different definitions of homelessness depending on exactly which governmental organization you work with, and that has some impact on our funding, but generally it's really someone who has unstable housing. As you will see here on this slide, someone who lacks housing does not have a primary residence during the night, or is in a supervised public or private facility, or is in transitional housing. It's one of the definitions. That includes people who are on the streets, in shelters, single-room occupancy. It also can mean folks who are what we think of at risk of homelessness, which means doubled up, couch surfing, or some other form of situation in which they're one step away from homelessness. There are a lot of factors that go into people experiencing homelessness, and I want to talk specifically about what we think of as individual and structural. We know that poverty impacts people entering homelessness, but there are a lot of other factors that are really significant. Early childhood adverse experiences have a remarkable impact on people's future risk of homelessness, as do mental health and substance use disorders, personal history of violence or TBI, and many other factors that you can see in this slide. LGBTQ identity is listed twice on this slide because of the significant impact it has. And we are seeing more and more in the recent past, older people are at risk of homelessness as well. I work in a shelter-based clinic, actually a homeless clinic that is out of a day center. And I am astonished at the 60-year-old and 70-year-old people who are coming through with serious medical conditions who do not have a place to sleep at night. Those are the individual factors. The structural factors actually play a more significant role for most people. This is what I think of as society, as things that political activism can change. Racism, absence of affordable housing, wage stagnation, unemployment, and changes in mental health funding. And in the last 60 years, we have seen a significant change in the funding for mental health services, and this has resulted in a large change in homelessness experienced by people who have mental health conditions. And the relationship between these two types of factors is demonstrated on this slide, which is, you can see, the green is the structural factors, those things that were over on the right side of the screen before, and the blue are the individual factors. And as individual factors are significant, the more individual factors you have, the fewer structural factors need to come into play in order to contribute to homelessness. But as those structural factors, whether it be racism, whether it be unemployment, whether it be wage stagnation, lack of affordable housing, as those get larger, the individual factors have to be smaller and smaller and smaller for people to experience homelessness. And I think in our recent in the recent past, we've seen greater challenges with affordable housing and mental health treatment, which contributes to increase in homelessness. And this is a slide that I made just to try and demonstrate how interconnected all of the different pieces can be for someone experiencing homelessness. Over on the left, you see the kinds of concrete things that I think of people losing, whether it be their job, their sobriety, their memories. And you can lose memories in a lot of forms. Sometimes it's people who have a traumatic brain injury and are no longer able to remember things. Sometimes it's more concrete, and it's someone whose possessions have been swept by the police, and they lose all of the photographs they had of their family, of their friends. Sometimes you physically lose your identification, and when you lose these things, then you start to lose track of your self-respect, your connection, your identity, your hope. And so this is a slide that I created to try and show just a complex web of both the concrete things that people can lose as well as those pieces that are really important for their identity and their ability to have hope and move on. Alaina is now going to talk about the intersection of health and homelessness.
Hi, great. Thank you, Eowyn. And I just wanted to briefly talk about really kind of giving a snapshot of really the state of homelessness in the U.S. And so I felt like this was really important before we started talking about bundles of care to really get a good understanding of the diversity and what people experience. So one of the ways that we can look at homelessness is through what's called a point-in-time count, which is done annually, and you'll often see this in the literature written as an X number of people experiencing homelessness on a single night. And in 2016, they found that there were nearly 550,000 people experiencing homelessness in one given night. And so that's through efforts of individuals going out at night and canvassing and trying to identify individuals that might be on the street, in bridges, in shelters, in those sorts of places. You can imagine that there's also has some gaps in terms of some might go uncounted. So we do call these estimates. And this is normally run through HUD, which is the Housing Urban Development Department. And so on this slide, what you're looking at are three different categories: the housing status of those individuals that were measured, the race, as well as the gender. And what we're seeing is that the majority of individuals that were surveyed were mostly people in families that were sheltered, or they were individuals that were sheltered. But there's a wide spread across all of these categories as well, so a lot of the individuals that are also unsheltered. And looking at race was mainly predominantly white or African American, and then gender is still mostly male. Another way that we can also look at homelessness and get an idea of the state is through what our health centers see. So looking through the lens of our health centers, we do see that 1.2 million, more than 1.2 million patients that were experiencing homelessness were seen by health centers that were federally qualified, and that was nationwide for 2016. When you just look at health centers that receive and take care of individuals specifically experiencing homelessness, they saw over 900,000 of those patients. And when asked specifically, nearly 900,000 of those self-reported as experiencing homelessness that walked through the doors of our clinics. So as you can imagine, most of those are experiencing 100% and below federal poverty level. And again, just looking at the 2016 housing status, you can see a wide spread of either individuals that are being currently housed in shelters, doubling up, or transitional housing. So again, just kind of thinking back to those definitions that Eowyn shared with us a few slides ago. So to think about this intersection between homelessness and health, just spend some time talking about this reciprocal relationship. And so we know that they do play off of one another. So individuals who are experiencing homelessness often have higher health problems, have more comorbidities, and really when you think about where some of those individuals have to take care of their wounds, you can see how their current situation of housing does impact their treatment and recovery. So taking care of wounds maybe on the street or in places that might not be the most clean. We also know that health problems can cause homelessness. Those that are injured or get ill on a job might find themselves in a situation where they might be becoming homeless because of bills that they might have to pay and costs related to the health issue that they encountered. And then we also know that homelessness causes health problems. So those that might end up on the street or in a situation where they do not have housing might be healthy when they get there, but exposure to the elements and those types of environment can cause problems as well. So you can see that there's an interconnection and a reciprocal relationship between the two. So when we just look at housed versus non-housed, we do know a couple of things. We do know that those that are non-housed have higher prevalence of physical illness, mental disease, or psychiatric disease, and substance abuse. We also know that drug overdose is the greatest cause of death, especially now with a lot of what we're seeing with the opioid crisis. We know that they're 8 to 9 times higher mortality rate compared to the general population. When just looking at individuals who are unsheltered versus individuals who are also homeless but might be in a shelter, we know that those that are unsheltered and homeless are 2 to 4 times more likely to die. We also know that looking at that same population, that they're 15 times more likely to die than the general population. So again, just kind of thinking about these statistics and the population of which our health centers serve when we start talking about the model of care. A couple of other things that are important to note, too, for those that might be less familiar with the field, is that those experiencing homelessness have higher rates of chronic disease. So again, looking at this list, looking at diabetes and hypertension and heart attack and depression, we know that they have higher rates of these conditions, and that results in a lowered life expectancy, which on average for individuals without homes is 12 years less than the U.S. general population. So again, kind of just considering those factors as we talk about this intersection of health and homelessness. So recently, some of you are probably familiar with the social determinants of health, and really we're all exposed to those determinants. All of us on our daily encounters probably have elements within our social network or what we experience on day-to-day and encounter in our interactions that might impact how we seek care, how we view care, how we access care. And so all of us really have an element of this. But I think what's important is that some have a greater magnitude of these determinants, and they might have more of these determinants as opposed to maybe just one or two that might impact some of us. So again, thinking about how homelessness can exacerbate some of these social determinants of health. And so in this next slide, overlaying individuals that are without homes, you can kind of see how those social determinants can be exacerbated in the general population. So when there's no affordable housing, the limitation results in people being on the street, and usually they're unsafe conditions. They might be exposed more, again, to the elements, but also to violence. And that also might impact the number of times they might be homeless or how many times they might be homeless. So kind of thinking about that, thinking about, you know, other systemic barriers that might lead to the prevention of seeking care. So some of those might be structural as far as access. But also thinking about networks. A lot of us rely on our relationships and who we're around to help us make sure that we're doing healthy behaviors and doing certain things. And oftentimes, and not all the time, but a lot of individuals that are experiencing homelessness might have lost some of those connections and might feel socially isolated. And losing that support might impact their health and seeking care. In addition, not only losing the healthy support, they might be more exposed to social networks and supports that might be negative, that might expose them to more risky behaviors or disconnections from those positive networks. So I think it's important to kind of think of all of these. And of course, you know, thinking about criminalization and homelessness and how does that impact health. So so keep that in mind as we continue to move through these slides. I do want to hand it over at this point back to Eowyn, who will talk a little bit more about the patient-centered care related to healthcare for the homeless.
So one of the ways we can address those social determinants of health is through patient-centered care. And this is actually one of the innovations that started within healthcare for the homeless and since has spread throughout the healthcare system. Because healthcare for the homeless has always been patient-centered. That's really at absolutely the core of what we do. Now, what do I mean by patient-centered care? I really mean that the patient is the first priority in the care. And you might think, well, that's obvious, but it actually often is not the case when you're in a medical encounter. This specifically means that the needs, the values, and the wishes of the patients are central when developing a plan. So how specifically might this show up when you are working with someone who is homeless and you're working in a healthcare for the homeless site? For example, actually just this morning when I was in clinic, I had someone say, hey, can I get my medications packaged weekly rather than monthly? Because weekly the bottle is so big and I have to carry around all of my stuff. So he had the opportunity to ask me that question. And we have a pharmacy that is flexible and willing to provide medication tailored to exactly what the patient needs. Another example might be the way in which we schedule appointments or don't schedule appointments. Whether you have walk-in appointments available, whether you have scheduled appointments, some combination of those. Having all walk-ins is harder for the system. And in some ways, it is better for the patient. So it's actually complex, but having some availability of drop-in, very low barrier care is really important. And one of the reasons is when you think about all of the different priorities that our patients are facing, healthcare is not really high on the list. They may need to get food. They may need to get shelter. They may need to make sure their stuff is safe. That all of their belongings don't get stolen or swept. In some cases, they need to find the substances that they use every day in order to feel normal and function. And so recognizing all of those complex pieces that go into decision-making really changes the way in which we provide health care. Some of those specific changes can be to systems, can be addressing groups and individuals. The organizational philosophy plays a really important role in how we implement patient-centered care. And the question is, who's the boss? Who's in charge? What are the questions you ask when implementing new programs? Are the questions that you ask, is this the best thing financially for the organization? Is this thing what's going to fit best into our existing programs? Or is this what is best for our patients? Most healthcare for the homeless organizations do patient satisfaction surveys, and they also have consumer advisory boards, which we'll talk about in a moment. So that's one of the ways that the organization can collect that information in order to be truly patient-centered. One of the things that we do exceptionally well at Central City Concern is making sure that all of our materials, and actually most of our communication, our verbal communication as well, is filtered through a lens to address literacy, so that people with lower literacy, both health literacy and just straight up literacy, are able to understand the materials we give them. Because that's a characteristic we know that is true for many of our patients, and so that's how we're trying to be patient-centered on an organization basis. And then one of my personal favorites is service agreements. You may have heard about behavior contracts in different organizations when a patient gets escalated, when they're having trouble interacting with staff, and there might be conflict. Often we implement what are called behavior agreements. But in our setting, or actually, excuse me, behavior contracts, even more punitive. In our setting, we've tried to shift towards service agreements, where we sit down with the patient and we say, we're having trouble providing you with services, and you're having trouble getting services. How can we work together? What do you need from us, and what do we need from you in order to work better together? Because especially for people with a history of experience with foster care, experience with the justice system, experience of incarceration, talking about a behavior contract is very triggering. Ways that you can be more patient-centered for groups is ensuring that your organization is as affirming as possible for people who are transgender and gender expansive. That can range from bathroom signs to registration paperwork to staff training. Having culturally specific programs so that people who come from different cultures are receiving care that is really tailored towards their experience and their perspectives. And then finally, ways in which the individual provider can have an impact and increase the patient-centeredness of their care is really about agenda setting. And again, what is the approach of the provider? Who do they think is in charge of the visit? Because often I walk in the room and I say, this is what we're going to do today. Actually, that's not what I do. What I say is, how are you? What is it that you want to talk about today? And then the patient sets the agenda, and I may add in a few things. They often don't necessarily want to talk about diabetes or high blood pressure, but I do. But really allowing the patient to be the person who is in charge, and then demonstrably shifting power to them. So saying, you can make this decision. I want to make sure you have the benefit of my understanding and experience of some of the medical details. I want to support you in making the decision that is best for you, not the one that I think is best. Alaina will now talk a little bit more about models of care.
Great, thank you, Eowyn. So before we get started with a few of the elements that I think make healthcare for the homeless health centers unique, I just want to go back for just a second to give to remind ourselves just kind of the diversity of the patients that that do encounter our health centers. And basically, I've gone through some of this already. We've already known that our population does have increased mortality, have more comorbid conditions, chronic conditions, and we know that they're more complex health issues related. They're encountering trauma almost daily, and that can look different. So all of these things need to be considered. So just kind of looking back and kind of looking at specifically healthcare for the homeless. If you look in the figure on the right, you can see that healthcare for the homeless here has seen nearly 900,000 patients. This is the 2015 data, so these numbers might look a little bit different from earlier. But really what we're showing here is that of those patients that walk through the door of our clinics, 94% of them have self-identified as experiencing having some sort of housing issue. Whereas when you look at the larger community health centers, you can see that of those that self-identify as having housing issues really makes up 5% of their total population. So again, kind of looking at somewhat of a homogeneous population, but within that, the heterogeneity within what they are experiencing. And so over to the right, you can see, again, what that spread looks like, and we're seeing mostly individuals that might be sheltered, doubled up, or transitional, but we also have a lot of other individuals that are experiencing homelessness differently. So with that in mind, the HCH model, or the Healthcare for the Homeless model, really focuses on an integrated multidisciplinary approach, which is really a team-based approach, like Eowyn was talking about, and I know she has some really great examples following this. But kind of looking at care coordination across different disciplines is really important. And how can we use this to improve the health outcomes of these individuals that might be experiencing homelessness, as well as address the patient-centered care needs that Eowyn also previously addressed as well. One important piece of information I think is important to note is that Healthcare for the Homeless was doing a lot of these requirements that are now seen within the patient-centered medical home requirements way before those became adopted by the National Committee for Quality and Assurance. So it's helpful to keep in mind that Healthcare for the Homeless was really starting a lot of these innovative things many, many years ago. But we also want to let you know that it is aligned with what the principles around patient-centered medical home are focused on. So looking at patient empowerment. As Eowyn just said, having the patient be in control of their care. Looking at care coordination and delivery of integrated team-based care. So we do align with what is called PCMH, the patient-centered medical home. So looking at integrated care, I've just made 4 buckets here to make things a little bit easier to look at. Nothing special or different than maybe some other models you have seen, but really kind of looking at integrated care, looking at the primary care and behavioral health being in the same place. And that leading to coordinated care and connection to services that might look like case management or housing referrals or medical respite, discharging kind of planning. But also looking at integrated care as meaningful approaches to care. Do we have a trauma-informed approach that you're using in your organization? Looking at harm reduction as another approach that might be more meaningful and patient-centered. But also kind of integrated care in our world is also important to reduce the barriers to care. So taking the medicine to individuals that might be experiencing, that might be non-housed. So looking at street medicine or using community health workers as an approach or using medical mobile clinics as well to kind of go out. So all of those, I won't be able to touch on all of those, but hopefully I can briefly go through some of these points and things that I believe that make us unique, key components to our model. So just briefly, trauma-informed care. We do know that individuals that are homeless are experiencing trauma almost daily. And so it's important that they're able to get the access and care that they need in a trauma-informed manner. So what does that mean? It means that we're approaching individuals to mitigate the trauma and symptoms that they have. Organizations should look to not to re-traumatize that patient, as well as address the residual effects of the trauma that they might have experienced, again, from a greater risk of exposure to violence or even domestic violence or other types of trauma. And there are quite a few. Any organization can become trauma-informed. And it can happen at the organizational level. So looking at your mission statement and looking at the goals and the physical environment, training your staff on how to interact and encounter really is important to address the health of this vulnerable population. One of the key, most important pieces of what a trauma-informed care organization looks like is safety. Individuals need to feel safe when they seek care. And so I think that's something that's really a key element if you were thinking about trying to form your own trauma-informed organization. There are some resources at the bottom that we are happy to share when the slides are available, and they should be hyperlinked to individuals in our group that can take you more into more detail around trauma-informed care. Medical respite is something that the council here really is proud of. The National Healthcare for the Homeless Council was the leading organization for this type of care, and really what it is it's care after individuals are released from a hospital. So they might not be sick enough to stay, but they are too sick to recover on the street or, again, exposed to the environment or elements. So really giving individuals a humane place to recover is what medical respite is. So kind of looking at discharge planning. And so the council has been a lead organization in this. And in 2016, there were 80 known programs that were across 29 states and led to more than 1,500 new beds. More importantly, there's a group here that did spearhead a set of 7 standards that we would love to have people use if they want to start their own medical respite programs. It's a lot of lessons learned and other important requirements along the way. But we also know that the program Medical Respite shortens hospital stays, reduces admissions, and improves outcomes. I do want to be important in saying what medical respite is not, which is it's not a skilled nursing care, nor is it supportive care. But again, it's a short-term place for individuals to recover in a humane manner. Street medicine, again, is something that makes our health centers unique, and a lot of our health centers do this regularly. And it's, like I said, taking healthcare to the street, to where individuals are, and building that relationship, building the trust, because that is really important when it comes up getting individuals engaged with clinics. This can happen in fixed sites or mobile sites, so setting up a tent or a mobile unit can do that. A lot of reasons why, barriers of why people might be attending, might not come to a clinic are related to stigma or paranoia, and most importantly in encampments, a lot of people don't want to leave their valuables or belongings. So overcoming some of those barriers, or not overcoming those barriers, but having providers go to them are really important pieces to the council and model of care. Harm reduction, as I've mentioned before, is a pragmatic approach. How can we reduce the harm to individuals that might be taking part in risky behavior? So meaning to stay away from abstinence. It shouldn't be an ultimatum. And so how can we approach this in a low threshold way in which individuals can be encouraged to stop doing risky behaviors, but do that in a modular way and incremental points. So so those are important things, and I think one example that still I'm sure is controversial but has been successful in some places are needle exchanges as an example of harm reduction. Case management, some of you on the call might be very familiar with this. Case managers are a very important part of our health centers. They're often enabling services, so these are services in addition to your primary care, behavioral health, but individuals that might involve social working, connecting to housing, really important pieces to addressing individuals that have unstable housing. And instability is a really important piece in defining homelessness. So that was something to consider, and case managers management has a role in that as well. The most often type of case management model, there are 5 out there. A lot of ours focus on intensive case management, which is usually a caseload of 15 with a medium level of intensity with contact between clients. So there are some increased intensity after this model that you see on the screen here. Consumer advisory boards have been brought up before, and these are really what helps us make the model be patient-centered. It's important to have the consumer have a voice, and we have a national consumer advisory board here at the council that really informs our day-to-day work and really helps in decision-making. And this is done at the local and national level. As I said, nationally we have our own CAB, but a lot of our health centers have their own local consumers as well, and this should be a part of the decision-making process and help to inform the activities within a health center. So these are really important opportunities for individuals to develop these leadership skills that can help them move towards independence and moving out on their own. So that's an important piece of the model. One piece that I think is important here is talking about tailored services. So there is a piece of data that we can obtain where our health centers write in other services that they feel that they provide. And so looking at those services that they felt weren't captured quantitatively, they wanted to make sure that that people were aware that they provided these services as well. So what you see on the screen is those services that were reported divided up into 3 categories: professional services, enabling services, and related services. And the size of the font is supposed to indicate the number of times a health center said that they provided those services. So as you can see here, we have individuals or health centers that really focus on podiatry because we have a lot of foot problems within our group, yet it's not captured most often in a lot of health measures that are reported to some of our national entities. So I think that's something that's really important to remember. Also, as we move over to enabling services, there's a lot of eyeglass services, so a lot of vision is something that's important that is done at our clinics. Dental is also something that is integrated into our health centers as well, so a lot of oral health attention has been spent at our health centers. We also have in enabling services navigators and other shelter and housing referral agents that can help with that. So it's really important to also consider these services as part of the model. What else are our health centers doing? We also see clothing and offering foods are food and meals. So a lot of our health centers might be within a lot of food pantries or shelters as well. So again, keeping in mind it's not only primary and behavioral health, but what else is being provided are important to remember as well. So with the few minutes we have remaining, I want to hand it over back to Eowyn so she can share with us some of her examples at Central City Concern. Eowyn?
Thank you, Alaina. So Alaina was saying that not just primary care and behavioral health is essential for integrated services within healthcare for the homeless, and that is certainly true at Central City Concern. We do have integrated behavioral health. We also have substance use services, wellness classes, and acupuncture available in our building, which you see here in this picture. And then we have access to more comprehensive mental health services, more comprehensive substance use services, housing, and employment services. So when you see this building here, this half of this building, this half over here, is primary care. And about this half is comprehensive mental health, so people who need a higher level of care than the integrated behavioral health that we have within primary care. This building is recovery housing. So this is housing for people who are engaged in substance use treatment. And then across the street, over here, if we had a bigger picture, is part of our substance use services division, which provides 3 times a week outpatient groups for people engaged in substance use services. And then down the street here, 6 blocks, we have a clinic that is based in a day center, which you'll see another picture of later. And then we have housing, kind of in the entire neighborhood. We've housed 1,700 people through Central City Concern. And then down the street this way, we also have an employment services office, which helps people to gain employment and actually offers them some employment through our organization. So we're really lucky to have all of these services, and I recognize there's lots of organizations that don't have all of them, and they're not essential for good care, which we'll talk about in a minute, but this is what is possible, and these are the things that really help people not only to be healthier, but also to move out of homelessness. So I want to talk to you about a few of those people. These are patients. These are actually, none of these are specific patients. This is an amalgamation of some individuals that I have seen. So if you were to happen to hear something that sounded familiar, if you were in Portland listening to this call, none of this is based on an actual individual. It's just a collection of characteristics. But James is representative of one of the challenging situations that we often face when we're in healthcare for the homeless. He's a 56-year-old new patient who comes in and he has a lot of trouble with communication. And it's really interesting in homeless health. You're not quite sure what the cause of that might be. It could be mental health. Perhaps he has really loud auditory hallucinations that you're not a part of, and he's distracted by them. Perhaps it's substance use. Perhaps it's sequelae from substance use. Maybe he has some brain problems, some cognitive problems from substance use. It could be a traumatic brain injury. It could be related to medications that he's taking, PTSD, or a developmental delay. So this is a puzzle that we often face in primary care working with people experiencing homelessness. And within our clinic, the first thing we can offer, and the most important thing that we can offer, is a primary care provider who cares, someone who genuinely wants to work with James, wants to provide patient-centered care, for whom the relationship with James is first and foremost. We are also lucky in that we can offer a psychiatric provider, an alcohol and drug counselor. If he's having trouble managing medications, we have social workers and occupational therapists who can help him manage a plan for taking his medications on a more regular basis. Our pharmacy can also actually work with folks, whether it be med boxes or reviewing their medications and helping them understand them. And then we also have counseling and wellness classes. So those are some of the ways that we can wrap the model around James to support him in order for him to build and gain strength so that he can then hopefully eventually achieve self-sufficiency. FENDER is a 33-year-old on his way to the fishing boats in Alaska, and his money ran out in Portland. And then he got the flu on the bus. And he came to see me in that clinic that I mentioned in the Homeless Day Center. And this is that clinic. So you saw that big, beautiful building in the previous slide. This is another place where I work, which is quite literally a hallway and a room. And people walk through the hallway and they set off the alarm, and we're trying to take care of patients. And there's a little library back here, and they come in to get their books, and we're trying to maintain privacy. But that is actually my personal favorite clinic, because it's the one where we get people who are just coming through and need some support. And so we have an opportunity to work with them really early on in perhaps their willingness to engage in the healthcare system. Because a lot of people who we encounter in homeless health have had very difficult experiences with the healthcare system. They're not treated very well. They're not treated kindly. People make a lot of assumptions about people who are homeless, that they're all drug addicts, that they have mental health problems, that they make a lot of assumptions about them. And that impacts their willingness and ability to interact with the healthcare system. And so this lovely little clinic gives us a chance to start to build on people's humanity. So what we can offer FENDER, first and foremost, is kindness and connection. We have community health workers who sit at that table in that hallway and connect with people regardless of whether they want to see the medical provider. They actually talk with people. They have 2 and 3 and 4 times more connections with people than I do as the provider, doing all kinds of things, helping them with getting free medications. In this case, FENDER, I did start him on an antiviral because of some other health conditions he had and because he did have the flu, and he came in to see me 12 hours after his symptoms started. I also gave him some socks, which he was delighted about, especially in Portland where it is wet, and people have a lot of problems with their feet when they don't have a place to get them dry. And then we can navigate. We can help FENDER get into primary care services and perhaps shelter, perhaps housing, perhaps employment, all of those other things that are going to help him have a better and more independent life. So Dusty is a 22-year-old transgender woman. She lives under the highway overpass. She is someone who is not engaged in health services, perhaps because she had really bad experiences. Maybe she was in the foster care system and she was forced into mental health care. Maybe because she uses opioids. Actually, no, the next person uses opioids. Maybe for other reasons. She's been treated badly. But she has some sort of breathing problem that this outreach team has noticed, but she won't talk with them about it. And so they are very regular. They come once a week, and they offer toiletries, and they offer food, and they build relationship very, very slowly to start to break down some of those walls that people have put up to protect themselves. So the things that our team can offer to Dusty when they're doing outreach on the street, and we do not have an outreach team at Central City Concern, but there are outreach teams around the country that do this kind of work, is a consistent, non-threatening kindness, an approach that supports her in her freedom to exist and make her own decisions and wants to just care about her and connect her with care. We can also offer very low barrier healthcare services, and if and when she's ready, navigation to higher levels of care. And Sharon, who does use opioids, is a 35-year-old opioid user, homeless, and she's being discharged from hospital after 3 days for abscesses and cellulitis. And one of the most important things that we can offer Sharon is a provider who is non-judgmental. Substance users have a lot of difficulty engaging with the healthcare system because they are usually told that they're wrong, that they're bad, that they're dirty, that sometimes that they don't deserve to exist and that they don't deserve to get health care. And so every encounter I have with people who are using substances, I'm trying to counteract that. I'm trying to say that you're important, you're valuable, you can make free choices. Often, if we look back at the history of their substance use, it was a response to a situation. I remember vividly a few years ago, I was seeing someone and he said, I started using meth to stay up all night because I got beat up one night and I never wanted that to happen again. And that was a moment in which my thinking shifted about substance use, is that he was using it as a tool for his own personal safety. And it was really, it's very hard for me to have a negative attitude towards someone trying to be safe. Back to Sharon. So we can offer non-judgmental care. We can also offer our recuperative care program, which, as Alaina mentioned, is respite care or recuperative care, an opportunity to be indoors for a period of time to recover from an acute medical condition. We can offer primary care, mental health treatment with trauma-specific therapies, so EMDR, which is I always forget exactly what it stands for, eye motion desensitization reprocessing, I believe. Medication-assisted treatment, and that could be buprenorphine naloxone, also called Suboxone. It could be naltrexone. Referral to syringe exchange if we want to support the harm reduction, the most harm reduction approach, and recognizing that she may continue to use. Detox, and recovery housing. And that may be abstinence-based housing, or it may not be abstinence-based housing. But ultimately, having a non-judgmental provider is going to be the thing that allows us to connect Sharon to all of these other services. Which brings me to our final slide, which is the special sauce. In Healthcare for the Homeless, we do bring a very special approach to providing care to our patients. Our sophisticated, integrated, complex services are not nearly as important as that special attitude that need to put the patient at the center of all of our work. Having a desire for a true heartfelt connection and respect for all of us, that's fellow workers, staff members, patients, as fellow human beings, interest in working with people on their priorities at their pace, and an understanding that housing is essential to health. In all of the cases that we reviewed, housing is the ultimate goal to support people's health, as long as that is the patient's goal. There are some times when that is not the patient's goal, and then health without housing would be the goal. But ultimately, allowing people the opportunity to make a choice to be in housing is really the very most important thing we can do for their health. And this is patient-centered, trauma-informed care, which is what we do at Healthcare for the Homeless. Thank you.
Great. Thank you so much, Alaina and Eowyn, for your thoughtful presentations and the great information on how patients experiencing homelessness are impacted by the social determinants of health and the overviews of team-based and patient-centered care. At this time, we would like to open up the presentation to questions from our attendees. For our participants today, if you haven't done so already, please enter any questions you may have into the chat box below the presentation slides. The first question that has come in is for both of our presenters on consumers and patient advisory boards. Do you offer any training or skill building opportunities for people who are interested in stepping into an advisory role? If so, can you please talk about your curriculum?
Well, sure. This is Alaina, and then Eowyn, feel free to jump in whenever. But I just wanted to give an idea of what the council can provide. So the council does have training and technical assistance for this area around consumer engagement and patient engagement on boards. So we'd love to have you ask a question or request any kind of information. We have curriculums and one-on-one intensive trainings as well around consumer advisory boards. So that can be done through virtual training as well as brief TA. So that is open and available for all of you on the call to partake in. So I think on the question screen there is contact for, and I'll just switch to it now, on how to access that for technical assistance. That is what we're here for, so please reach out. And Eowyn, I'm not really sure if you wanted to talk about your board or patient engagement in your health center.
Within our individual health center, we do some training of our Consumer Advisory Board. A lot of it is using the Consumer Advisory Board manual that is available on the National Healthcare for the Homeless website as well.
Great, thank you. The next question that has come in is, do you use a peer model, and if so, do you pay your peers?
This is Eowyn. Within primary care, we have community health outreach workers, many of whom are peers. And then within our comprehensive mental health system organization, we have peers who are working directly within the mental health teams. And yes, we most certainly do pay our peers.
Perfect. Thank you, Eowyn. It looks like at this time we don't have any additional questions answered. I'd like to give the attendees one more chance to enter in any questions they have. All right, well, it looks like we don't have any other questions at this time, so thank you again, Eowyn and Alaina, for your presentations. And for our attendees, thank you all so much for joining today's webinar. Presentation materials and a link of the archived webinar will be available on the Council's website, www.nhchc.org, within 3 business days. A survey for evaluating today's